I hope you had a good lunch. Let's see if you can stay awake. I will be talking about Moyamoya disease, and I will start by talking a little bit about what it is, because it's uncommon. I guess many of you know, but just to get on the same page, talk a little bit about the cerebrovascular reserve and the acetazolamide challenge, how we do Moyamoya disease imaging at Karolinska, some cases, and some initial data from our retrospective study. So Moyamoya is an idiopathic, primary progressive disease of stenosis of the distal carotids and the circle of Willis arteries, and it is related to genetic changes, particularly a mutation in the ring finger 213 gene. And there's also this picture of a very class-specific collateral recruitment. Then we have also Moyamoya syndrome, which is when the imaging fits with Moyamoya, but the disease is caused by some underlying syndrome or other disease mechanism, like atherosclerosis or neurofibromatosis and so on. And in both cases, you have a progressive cerebral ischemia, which leads to symptoms in the form of transient ischemic attacks, strokes, and hemorrhages, but also more subtle symptoms like atrophy and neuropsychological symptoms. Here is an example of the a normal DSA and a Moyamoya patient, and we can see this characteristic narrowing of the terminal carotid and the an occlusion of the left MCA and stenosis of the left ACA. And then we see this extensive collateral network termed Moyamoya vessels. It can be unilateral or bilateral. Many think that the primary Moyamoya disease should always be bilateral, even though it may start unilateral, but I don't think there's a complete consensus on this. You can also see unilateral, of course, in the secondary Moyamoya syndrome. And then we have these collaterals that appear. This is a case from a 56-year-old female with what I would term moderate collaterals. We see centrally near the occlusion and in the basal ganglia more vessels than you would normally see. And on the external carotid injection, you see some distinctive dural peel collateralization from the branches of the STA. But it can also be much more extensive. This is a 7-year-old male with a very large central collateral network, and this is the origin of the name Moyamoya. It means puff of smoke in Japanese, which is the angiographic appearance basically of these vessels. This patient has also had burr surgery, which has promoted inflammation and angiogenesis, showing a lot of secondary transdural collateralization. I want to talk a little bit about atrophy, which you kind of forget about Moyamoya. You think about the strokes, but since it's a chronic ischemic syndrome, you see a lot of atrophy as well, and we are increasingly aware of this, the importance of this for the patient. This is an example from a study by Zhou et al. In 2023, showing atrophy in the central gray matter, most apparent in the thalamus, putamen, and hippocampus. But there's also, it's very hard to see on here, but I hope you who see the screens maybe can see that there is distinctive thinning of the anterior corpus callosum, so there's also a lot of white matter atrophy in these patients. And progression can be quick. Here is an example of a 5-year-old male who we scanned last week, and as a follow-up study, he has bilateral Moyamoya and presented in February with a left-sided basal ganglia stroke, but was imaged initially in about 14 months ago. And already in this time, you can see widening of the lateral ventricles, more apparent on the side of the stroke, of course, but even on the right side. And also thinning of the anterior corpus callosum compared to the baseline. So this is the thinned version, this is the baseline. So the treatment for Moyamoya is relatively complex and risky. You need to do some kind of revascularization to help supply the brain, and the most probably most common treatment is synangiosis, which has a long and complicated name depending on which kind of tissues you use, but basically you create a cranial window and attach or adapt extracranial vessels and the surrounding tissues to the brain surface in order to promote collateral ingrowth. You can also do burr hole, as I showed the example of previously, where you simply drill a couple of small burr holes, which will promote inflammation and create this collateralization. But it's also dependent on creating a hole all the way down to the pia. And this is more often used in children because it's a less invasive procedure and might be easier to do. Probably the most effective treatment is STA-MCA bypass, but this requires sufficient width of the external donor vessels from the external carotid artery. So some patients have to be excluded from this treatment option because of basically the technical reason. And you have to work fast to be able to do the anastomosis without getting thrombosis in these vessels. So this is an example of synangiosis where external carotid artery branches, STA, and also I think from the IMEX, have been adapted, and you can see that they now supply in the capillary phase a large part of the right anterior circulation. So in order to select patients for this treatment, since it's very risky, we have to do it when the patients really can benefit for it, but not when it's not necessary. And an important help for clinicians here is evaluating the cerebrovascular reserve, which is defined as the brain's ability to increase the blood flow in response to vasodilatory stimulus or increased metabolic demand, which we have talked a lot about today with oxygen extraction fraction and the microvascular changes. And here is an outline of how cerebrovascular reserve, or CVR, changes in relation to vasodilatory provocation. So in a normal patient, you would see you have a normal baseline blood flow and it will increase after provocation. Whereas if you have reduced cerebrovascular reserve with disturbed microcirculation, you might have a decreased baseline blood flow or normal, and the increase after stimulus is very small or absent. Whereas in the cases of completely depleted reserve, you have a decreased baseline CBF, but you also have a further decrease when you provide vasodilation, mainly due to shunting phenomenon, probably. Here's an example from a oxygen 15 water PET showing, for example, an area here where after vasodilation blood flow decreases, and then if you calculate CVR from these maps, you can get a sense of the affected area. And if you see progression here in patients that are followed up, you might want to do something, basically, even if they haven't had a stroke or ischemic attack. So in our clinical practice, and I think probably most commonly, we use the acetazolamide challenge to do this vasodilatory stimulus. You give acetazolamide, which is a relatively cerebral-specific vasodilator, and you do first a baseline perfusion, and in this case CTP, and then give the drug, wait 15 minutes, and do a perfusion again. And the most important thing here is what happens with the CBF. So in this patient with depleted CVR, bilateral anterior circulation, we see decreased CBF compared to the posterior at baseline, and after vasodilation it decreases further, whereas in the posterior circulation there's the increase that we expect. And the reverse is true for TTP, obviously. Flow is slower, but becomes even slower after provocation. So here is a model of how the perfusion changes may happen. This is a proposed model. And the figure is from our colleagues in Uppsala in Sweden. And what we think, or our hypothesis, is that you can detect these microvascular changes and their progression before you can actually detect changes in the CVR by changes in cerebral blood pressure, blood flow rather. And we'll see if that is the case, but if we could, then we could do a lot more with our perfusion maps than we do today. So at Karolinska, we since about 3 years ago, we, together with Uppsala, are national centers for Moyamoya disease and syndrome, meaning all patients with known or suspected disease are referred to us for treatment and workup. And this includes also cases then that turn out not to be Moyamoya, but where the initial imaging, for example, a CTA, might indicate so. And what we do is we do repeated MRI examinations to evaluate CVR, and usually do a DSA as well, especially in the initial stage, to look at suitability for revascularization and how the collateral network is laid out. So when the Swedish government decided to centralize Moyamoya care to these two centers, we decided to design a specific MRI protocol for these patients, which we didn't have before. So the whole basis now is to do a retrospective study of the patients we've scanned so far, and we will keep adding patients as we scan them. But what we have done is, since 2022, we've scanned about 59 patients in 78 scans. So some of them have been examined multiple times, either just a standard follow-up or before and after revascularization, for example. And these are the baseline statistics. So what we want to do with our protocol is we actually devote quite a lot of time to them in the MRI. And we do a big, comprehensive study to try and both evaluate for other diagnoses, such as vasculitis, which is why we do vessel wall imaging. But we also do a 3D T1, so we can do volumetry and evaluate atrophy. Currently, we're doing it with the automated Combinostics AI to help with volumetry, in addition to regular subjective evaluation. And with regards to perfusion, we actually do DSC before and after acetazolamide challenge. So many centers do all of their scanning with ASL because it doesn't require the contrast and all of that. But we think that DSC, especially with the Circuit suit, is a more stable estimation of CBF, and that we can get a better, more robust quantification, basically, and an easier way to compare between follow-up studies and so on. But we do our ASL for quality control, so we have ASL before the challenge as a baseline, but due to timing and ethical reasons, we didn't extend it to also do it afterward. So I want to show some cases of what it looks like. Bear in mind, again, this is patients both with MMD and syndromic variants. And we do both pre and post acetazolamide maps with Circare. I will show some pre-maps, but I won't show the post maps because it's hard to quickly identify if something has changed, especially from the back row. So I think it's very helpful to actually calculate a delta map. And this delta CBF is basically CVR, right? What happens, is there an increase or a decrease? But we can also calculate that delta maps for all the other parameters and try to understand what happens with those. And to help with this calculation, we do co-registration of the pre and post acetazolamide studies, and also apply some blurring to minimize the effect of any misregistration. I use this color bar scale, so just so you understand that a value of 1 means no change, yellow, and if it's green, it has increased, and if it's red, it has decreased. I thought that might be simple to understand. Here's a 25-year-old female with bilateral Moyamoya. She has mainly affected frontal lobes. So you can see in the delta CBF map here that flow decreases bilaterally after acetazolamide, and in both the watershed zones and the anterior ACA territory, whereas the posterior MCA territories is less affected. There is some effect here, but there's probably a lot of or sufficient PL collateralization from the posterior to supply the posterior MCA territory. But you can see that the COV or relative transit heterogeneity is decreased in the watershed zones, and CTH is markedly increased. And you can see after acetazolamide, CTH increases even further in the watershed zones, along with TTP. So this is another 25-year-old female with bilateral disease, and she has a kind of different picture, right? She has sort of preserved reserve centrally due to extensive central collaterals, whereas in the cortical areas, in the anterior circulation, she has a reduced CVR or depleted. And you can see quite deranged CTA in CTH in these areas as well. But we do see in most areas CTH decreases after provocation. More superior in the same patient, we can see that the depleted CVR lesion is larger. And this is quite common in these patients, that disease is typically more severe, more superior, which is kind of understandable because the central collaterals can't reach. Some patients, for some reason, get a lot of transdural collateralization spontaneously, and these don't have that pattern, but this is quite common otherwise. Still, we do see in the cortex, superiorly TTP decreases as it would in a normal brain, so to speak, whereas in the rest of the brain, TTP increases in the superior parts here. There's another case of a 38-year-old female with, she has a confirmed ring finger 213 mutation, so this is primary Moyamoya and bilateral disease as well. She has almost the inverse pattern, right? She's got a lot of reduced CVR centrally, but cortical sparing. And this is, she has quite a lot of transdural collaterals. So it's hard to understand exactly what is happening, but these patients have a lot of, they have a disturbed angiogenesis. And this means that they might, even though they get these stenosis, they also get like hyperangiogenesis and a lot of collateralization. And in this patient, it happened to be able to preserve cortical flow. However, the COV and delta CTH maps are pretty hard to understand in this case, and this maybe goes into what we have spoken about earlier, that you want a robust technique, and sometimes it doesn't work, and you have to understand when it doesn't. So maybe someone from Circer or Life can explain what is happening, but if it could be a calculation error or something. What we do find is that CBF and TTP seem to be, as well as MTT, seem to be much more stable, behave as you would expect generally. You can see on the pre-maps that CTH is markedly increased in the entire anterior circulation, even in the areas where the CBF or CVR is preserved. And then this patient underwent revascularizations, which you can see here, synangiosis with burr holes and the enhancement on the PL surface. And now you can see a much better CVR here in the left anterior circulation. But there was about 1 year between studies, and on the other hand, the flow looks worse on the right side. So simply it could be disease progression, but in these cases it's important to correlate with DSA. And again, hard to understand what COV is representing here. If I put them next to each other, it becomes more clear what's happening. And you have this CTH increased lesion in the affected area, which is much more apparent post-revascularization than pre. Again, not saying it's because of revascularization, could be just a primary progression of the disease, but it's something we have to try to understand. Here's another case of a middle-aged male with left-sided MMD and a large stroke with a correspondingly disturbed CVR and hard to interpret maps. Adding OEF and CMR02. So here are some overall group level data on these patients. We're interested in seeing, is there a clear signal indicating whether any of the pre-acetazolamide maps can predict what happens after. So in the legend here you can see that we've split the voxels, so any voxel with a positive CVR will have a green, with part of the green distribution, and negative CVR part of the red distribution. And what we see is that they're pretty much on top of each other. They are different, obviously, and in general, fewer voxels have a depleted CVR, so that's why those are lower. But there's not a very obvious signal here discriminating the groups. Which is not too unexpected when you're just looking naively at the voxel level. This is not, selecting for affected areas, the territories, or cortex versus white matter, and so on. If we instead look at the distribution of the delta maps, so what happens after, there's a little bit more separation, but still a lot of noise. But now you can see the kind of behavior that you would expect. COV decreasing, or lower rather, CTH increasing, delay increasing, MTT increasing, oxygen extraction fraction increasing, CBV, CMR, and TTD are relatively unchanged. Again, at the group voxel level. So we wanted to further try to understand, could you formulate a simple decision rule to decide, based on the pre-CVR maps, pre-acetazolamide maps, if there was a reduced CVR? And therefore we trained a random forest classifier, which had a low accuracy, so probably no. But interestingly, here is a graph of the feature importances. The model used TTP and delay as the most important features to separate voxels into high and low CVR. And delay and TTP are very closely related measurements. So we retrained the model without delay and also without CMR. And now it's even more clear that the biggest difference separating these at the voxel level is TTP. But again, it's not a useful model for clinical determination. It's more of a data exploration model at this point. So what we want to do next is dive down deeper and segment all the affected areas based on imaging and also based on symptoms and previous strokes, and try to predict, try to see if we can improve our model. Also use maybe a little bit more sophisticated ML techniques than just random forests, which I guess we've spoken about earlier as well. We're also very interested in seeing if these parameters, both the delta maps and the pre-maps, can predict what will happen with CVR in the future for this patient, how or when, in what timing their atrophy will develop, and whether they will respond good to revascularization surgery. And as I alluded to earlier, we also want to do a comparison of the robustness of ASL versus DEC. So this is where we are at the moment, so stay tuned for an update in the next year or so. Thank you.
Thank you very much for really exciting. My head is exploding. I don't know whether it tells, but some really exciting data. Are there questions from the audience? Because I was really, it's really interesting that you asked that question, whether, reductions in vasoreactivity, whether that is actually something that is caused by, this very chaotic microcirculation you see here. And it's really, really intriguing. I know I have an opportunity to come and talk to you and see your data, and I'm completely, that will be happening soon. It's very, very interesting.
It's a little teaser, this. So.
Yes.
Thank you for your presentation. Did you try to compare with the severe stage on DSA?
No, but that is the next step, basically, what I mentioned, just correlating with, since we have this extensive protocol, we will be doing a lot of Suzuki grading. Usually, all of them have a DSA at some point, maybe not exactly, all of them don't have a DSA at the same time as the study, but relatively near. But we all have the MRA, so we can do that. So do grading, look at affected hemispheres or vascular territories, and also look at quantify or systematize the collateralization, see how it looks at the transdural level, for example.
I was just curious, do any of these patients develop leakages or blood-brain barrier permeability at any point?
I can't say, I can't deny or confirm at any point, but in my opinion, or my at least our subjective sense when looking at all the cases we've done so far, there's usually not abnormal contrast enhancement, at least.
And there wouldn't be a reason for looking for it either. I was just curious.
Yeah, but we do T1 post-gadolinium on all of them, so that we can certainly use that to try and find those.
Really look forward to looking more at this and hearing more. There is one there. Yeah, Hatsu.
Can you hear me? Yes. Thank you for your presentation. There was a lot of information here, so I'm not sure if you answered some of it, and I don't know, because this is very new for me. One question I have, I guess you haven't looked at the MR perfusion, like how severe the MR perfusion is, to see if, when the patient goes to surgery, how they what do you call, react, or the recipient artery is actually revasculated. Right? You haven't looked at that yet.
Not systematically, but one of the cases I showed with revascularization, it's typically very apparent when we just when we look at them for reporting, that exactly where you have the synergiosis, you see much better flow, and sometimes it takes a while with direct bypass. It's probably evident right away, but with the synergiosis, it probably takes a little while for the vessels to grow, and how it grows is a little bit random, and I guess depends on the angiogenesis signals in that chaotic tissue there. So it's quite different how large the area is in which CVR is improved.
Because as from a surgical perspective, it will be interesting to see the MR perfusion also in the external, to see how the vessel is, and so if that's the right recipient to use for the bypass.
You mean if it has enough flow in
exactly, because sometimes you can, there's some places they have a standard surgery where maybe they will change your.
We see that the vessels grow. So we do a DSA pre-surgery, and then measure the vessel to make sure that it's big enough. And then when on the follow-up MRI, the vessel is like twice as big, so it will grow to fill its new shoes, its new role.
I think it would be interesting to see the collaterals at the same time as looking the severity of the MR perfusion deficit as far as post-op.
Yeah,
I will look forward to hear that.
Great, thank you. And there was a question here.
Thank you for your talk. Have you used multi-phase ASL or used this?
No, not that I'm aware. I don't think so. The standard, but we are considering doing an ethics application to be able to invite some patients that have interesting situations on the DSC and do ASL pre and post acetazolamide to compare and see what happens, and then we can do a little bit more extensive ASL. Interestingly, our colleagues at Uppsala, I think they maybe presented that last year at the Perfusion Summit, I don't know, but they did a study where they did ASL several times after acetazolamide injection, and they saw that CVR has there's a dynamic as well in the time after. So it's if you only measure 15 minutes after, like we do, it's not for certain that you're capturing the moment of worst or best CVR, so to speak. So it's yeah, all of these processes are very dynamic.
Thank you so much. Let's give a hand to Master.
Thank you.
Really
Thanks.
fantastic.
Thank